This presentation reviews the 2026 epilepsy paper by Winston and colleagues, developed by the International League Against Epilepsy Neuroimaging Task Force. The subject is structural MRI in infants between 1 and 24 months of age who present with a first febrile seizure or with new-onset epilepsy. Across the included studies, 2% of infants who underwent MRI had abnormal findings. That is a high diagnostic yield. At the same time, the certainty of evidence was very low, so the recommendations are conditional. So the core question for this talk is simple. MRI can be highly informative in this age group, but decisions still have to account for sedation, access, urgency, cost, and local expertise. Infancy is a high-risk diagnostic window for epilepsy. Epilepsy incidence is highest early in life, and seizures in infancy are more likely than seizures in older children to be associated with structural brain pathology. Early neuroimaging can influence diagnosis, prognosis, treatment selection, family counseling, and in some cases surgical planning. But the clinical presentation is heterogeneous. A first febrile seizure is not the same as established epilepsy, and not every infant has the same urgency or risk profile. This creates the practical question behind this guideline. Should MRI be pursued broadly, and when systems are constrained, which infants should move to the front of the queue? Infant MRI is not just adult epilepsy MRI performed on a smaller patient. The Harness MRI protocol, designed mainly for adults and older children with focal epilepsy, emphasizes high-resolution 3D T1, 3D T2 FLAIR, and coronal T2 imaging. In a mature brain, those sequences are powerful. In infants, the brain is still incompletely myelinated. That changes lesion conspicuity and sequence utility. T1 weighted imaging and FLAIR may be less informative, while high-resolution T2 weighted imaging in more than one plane may be especially important. So the protocol question is tied directly to infant brain biology. The review was organized around 3 PICO questions. The first asked about diagnostic yield. Does brain MRI identify the underlying cause of seizures in infants with a first febrile seizure or new-onset epilepsy? The second asked about clinical predictors. Which features are associated with MRI abnormalities that explain seizure etiology? The third asked about the MRI protocol itself. Which sequences or protocols best detect abnormalities in this infant population? Those questions map directly to clinical practice. Is MRI useful? Who should be prioritized? And what should the infant-specific protocol include? The paper answers the first 2 questions conditionally and shows that the third remains a major evidence gap. This was a systematic review and guideline development effort, not a single-center cohort study. The panel included the ILAE Neuroimaging Task Force and external experts, including pediatric epileptologists, neuroradiologists, adult epileptologists, and methodologists. The group defined the PICO questions, searched Medline, EMBUS, and Web of Science through April 13, 2023, and reported the review using PRISMA 2020 methods. Risk of bias was assessed with the Joanna Briggs Institute checklist, and the final recommendations were developed using grade evidence to decision methods. The authors ask not only whether MRI is useful, but how confident we can be and how feasible implementation may be across different settings. The PRISMA flow diagram shows how broad the search was and how narrow the final evidence base became. The authors identified 867 records. After duplicates were removed, 270 records were screened. From there, 152 full-text reports were assessed and 17 studies were included in the final review. This narrowing tells us that the clinical question is common, but the direct evidence base is limited. Many studies did not focus on infants, did not separate infant data clearly, or did not report MRI findings in a usable way. So very low certainty is not a contradiction of the high abnormality rate. It reflects the quality, consistency, and specificity of the available studies. Across the 17 included studies, there were 209 infants aged 1 to 24 months. Of those, 753 underwent brain MRI, giving an overall MRI utilization rate of 62.3%. The evidence base was geographically broad, with studies from Qatar, Pakistan, the United States, India, Turkey, the United Kingdom, Lebanon, Sweden, and Italy. But broad does not mean uniform. Most studies enrolled wider pediatric populations, and infant-specific data often had to be extracted from subgroup reporting. Studies also differed in whether they counted only etiologically relevant findings or included incidental abnormalities. That heterogeneity is the reason the 58% yield should be treated as a strong signal, but not as a precise universal estimate for every clinical setting. For PICO-1, the key result is the diagnostic yield of MRI. Across all included studies, there were 209 infants, 753 underwent MRI. Among those imaged infants, 438 had abnormal neuroimaging findings, that is 58.2%. The range across studies was also high, from 48.5% to 72.5%. The paper notes that this yield is higher than is typically reported in older pediatric epilepsy cohorts. Reported abnormalities included malformations of cortical development, tuberous sclerosis, hypoxic ischemic injury, tumors, metabolic disorders, and other structural findings. The interpretive caution is that some studies mixed clinically significant and incidental findings. Still, the overall message is clear. MRI frequently identifies structural abnormalities in this population. The first recommendation follows from that high diagnostic yield. For infants presenting with a first afebrile seizure or with new-onset epilepsy, brain MRI is conditionally recommended, either in an emergency setting or a non-urgent setting, to identify underlying structural causes. The word conditionally is doing important work. The recommendation supports MRI, but it does not ignore the very low certainty of evidence or the practical issues of infant imaging. The clinical goal is etiologic evaluation. CT may have a role when MRI is unavailable, sedation is not feasible, or urgent causes such as hemorrhage, infarct, tumor, or hydrocephalus must be excluded quickly. But CT should not replace MRI when MRI is indicated and available. PICO-2 moves from the question of whether MRI is useful to the question of prioritization. The review identified clinical features associated with a higher likelihood of abnormal imaging: focal seizure semiology, abnormal neurological examination, seizure duration greater than 5 minutes, focal EEG abnormalities, developmental delay, and perinatal complications. In practice, these features are most useful when routine immediate MRI for all infants is not feasible. They can help decide timing, urgency, and triage, but they should not be used backwards. Their absence does not prove that the MRI will be normal, because structural etiologies can still be present without obvious focal signs. Think of these features as prioritizers, not exclusion criteria. The second recommendation is that infants under 24 months with high-risk clinical features could be prioritized for brain MRI, because these features may signal a higher likelihood of detecting an underlying cause. Again, the quality of evidence is very low and the strength of the recommendation is conditional. This is not a validated prediction model. It is not a scoring system where a certain number of points automatically determines imaging. Instead, it is an evidence-informed way to support clinical judgment. For example, an infant with focal seizures, focal EEG abnormality, developmental delay, or an abnormal neurological examination would reasonably move toward earlier MRI if scan access or sedation resources are limited. At the same time, clinicians should remain aware that local pathways, anesthesia availability, clinical stability, and family-centered counseling are part of the decision. This slide explains why the predictor recommendation remains cautious. First, many studies had reporting gaps. Infant-specific details on neurological examination, EEG findings, perinatal complications, seizure type, MRI timing, and imaging outcome were often incomplete. Second, definitions drifted across studies. Abnormal neurological examination could mean different things. EEG abnormalities were not always localized clearly. Birth complications ranged from prematurity to low birth weight to broader prenatal or perinatal concerns. Third, confounding was rarely handled in a consistent way. Few studies adjusted for seizure type, family history, age, or timing of imaging relative to seizure onset. And finally, many predictors came from broader pediatric cohorts rather than infants alone. The associations are clinically plausible, but the precision is limited. PICO-3 is where the evidence becomes especially thin. Only 6 studies provided partial or complete information on MRI protocol or sequence selection. None reported sequence-specific diagnostic yield or directly compared protocols in a way that could support an evidence-based recommendation. As a result, no grade assessment was possible for protocol selection, and the paper could not recommend a definitive minimum infant MRI protocol. This is a major point for neuroradiology practice. The review supports MRI in this population, but it does not prove which exact sequence package is optimal. The paper therefore points toward a separate consensus-based effort and toward future prospective studies using standardized infant-tailored protocols. This slide translates the recommendations into a practical clinical pathway. Start with the target population, an infant under 24 months with a first febrile seizure or new-onset epilepsy. Then assess urgency and feasibility. Is the infant stable? Is MRI available? Is sedation needed? Is pediatric neuroradiology expertise available? When feasible, brain MRI is recommended to support etiologic diagnosis and management planning. When resources are constrained, high-risk features can help prioritize earlier imaging. Focal semiology, abnormal examination, prolonged seizures, focal EEG findings, developmental delay, and perinatal complications. CT may be complementary in acute settings when urgent hemorrhage, infarct, tumor, or hydrocephalus needs to be excluded, but the pathway still treats MRI as the more informative etiologic modality. The implementation challenge is that benefit has to meet feasibility. Infant MRI may require sedation or general anesthesia to obtain diagnostic quality images. That introduces scheduling needs, monitoring, and family counseling. Safety may be acceptable in experienced settings, but feasibility varies by institution, patient age, comorbidities, and resources. Access also matters. Some hospitals can obtain urgent pediatric MRI with neuroradiology interpretation. Others have long wait times or limited anesthesia support. In lower resource settings, CT may be more available for acute triage, even though it is less sensitive for subtle cortical malformations. The paper's recommendations are therefore intended to support local diagnostic pathways, not override them. The right question is not only, would MRI help? It is also, how safely and how soon can we do it? The main strength of this paper is that it addresses a focused and clinically important population, infants with first febrile seizure or new-onset epilepsy. It also uses a transparent guideline process, including PICO questions, PRISMA reporting, risk of bias assessment, and grade. That makes the recommendations easier to interpret and critique. Another strength is that the authors separate evidence-based recommendations from areas that still require consensus or future research, especially the MRI protocol question. The limitations are equally important. Certainty is very low. Infant-specific data were often extracted from broader pediatric studies. Heterogeneity prevented meta-analysis. Protocol comparisons were not available. Clinical impact and patient-centered outcomes were rarely reported. The take-home message is balanced. First, MRI has high diagnostic yield in this infant population. In the review, 438 of 753 imaged infants had abnormal MRI findings, supporting the etiologic value of imaging. Second, the recommendation is conditional. The evidence points toward MRI, but the certainty is very low because of heterogeneity, indirectness, imprecision, and incomplete reporting. Third, high-risk features should guide urgency when immediate MRI for everyone is not feasible. Focal seizures, abnormal examination, seizures longer than 5 minutes, focal EEG abnormalities, developmental delay, and perinatal complications all matter. Fourth, protocol evidence is the major gap. Current evidence cannot define the optimal infant MRI sequence package. In short, scan when feasible, prioritize thoughtfully when constrained, and interpret the guideline as evidence-informed clinical support rather than a rigid rule.